Now my talk about what the IBDist should know about fecal microbial transplantation. Let us say up till now, we are far beyond achieving our goal of IBD treatment, which is controlling the inflammation and achieving remission, and all the therapies, steroids, anti-TNF, new agents, aminosalicylates. Up till now, still there is a gap for achieving the treatment. There is secondary failure, and there is multiple patients unresponsive to treatment. Hence, the development of new therapies and the investigation of alternative therapies are needed. Fecal microbiota transplantation could be the alternative. Fecal microbiota transplantation arises as an alternative therapeutic strategy for the management of several gastrointestinal disorders, including IBD, since the gut inflammatory process is frequently associated with dysbiosis. What does it mean? Fecal microbiota transplantation consists of a transfer of fecal material from a healthy donor via the lower GI or upper gastrointestinal tract, aiming to restore the individual's normal intestinal microbiota. Lessons from other diseases, I mean, most of the lessons we learned are from the use of fecal microbiota transplantation in Clostridium difficile infection. There is a large body of evidence proving the efficacy of the transplant for this purpose. What about the immune modulatory effects and the mechanisms of it? How the transplant or fecal transplantation, how it works? A healthy gut microbiota is characterized by abundance of two major phyla, Firmicutes and Bacteroidetes. As my colleague said, there is an imbalance between the beneficial microbiota and the harmful microbiota, and I will not repeat that. Fecal microbiota transplantation can increase the diversity of intestinal microorganisms together with rebuilding the immune system and maintaining the balance of intestinal microbiology. It limited intestinal permeability, inhibited intestinal epithelial cell apoptosis, re-established the function of the intestinal barrier, mitigated the production of pro-inflammatory cytokines, and restored the metabolism of secondary bile acids in the intestinal tract. Further, it could compete with or antagonize pathogenic bacteria in addition to enhancing insulin resistance. As a result, the patient's immunity is improved. What about the technique? Donor selection, preparation of the donor substance, and the way of delivery. Donor selection, the optimal donor stool profile is an area of great interest. Donor stool sources have yet to be standardized, and thus donor microbial composition varies significantly, potentially impacting fecal microbiota transplantation efficacy. To use related donor or unrelated donor, it's a transplantation. I mean, most of the transplant kidney or liver, we use donors who is related. Here, commercial stool banks offer the benefit of accessing a large unrelated donor database. In theory, this may offer greater collective alpha diversity compared to stool from healthy related donors, as related stool donors may be at risk of decreased biodiversity by living in a similar environmental conditions as the fecal microbiota transplant recipient. To use a single specimen or from multiple donors, it's not known whether individual donor versus pooled multi-donor stool protocols translate to more effective re-establishment of microbial homeostasis. So, according to the recent guidelines, age range from 18 to 60, BMI from 18 to 30 kilogram per square meter, and it's better from multiple donors was more effective compared with single donor, and unrelated donors are better. How to prepare? The stool requires a weight of at least 25 grams for lower GI delivery, and nearly half this dose in upper gastrointestinal delivery. The final fecal substance preserved frozen at -80. It's considered to have a maximum shelf life for 2 years. Prior to utilization, the frozen fecal material should be thawed at 37 degrees centigrade, followed by use within a period of 6 hours soon. The way of delivery, it can be delivered through the upper GI, endoscopically, or with the use of a nasogastric tube, nasoduodenal tube, or nasojejunal tube. If you use the lower GI route, retention enema, colonoscopy, or through capsules, which contain either the freeze-dried or lyophilized fecal substance. These are some drugs that used in the process of fecal microbial transplantation. If you use the upper route, you will use proton pump inhibitors and prokinetics. If you use the lower GI, you will need bowel lavage, specifically using polyethylene glycol preparations. A single dose of loperamide could be considered after the lower GI fecal microbiota transplant, and a minimum of 24-hour washing period is required from the last dose of antibiotics to fecal microbial transplantation. It's very good if your IBD patient has complicated with Clostridium difficile. It's good. Fecal microbial transplantation is considered approximately 90% success rate for individuals with recurrent or refractory CDI. In 230 fecal microbial transplantation was approved by the USA Food and Drug Administration for clinical applications for recurrent or refractory CDI. Could the successful story in CDI be applied in IBD? In IBD, the precise pathophysiology is not entirely clear, and the etiology is multifactorial, influenced by individual genetic susceptibility, environmental, external environment, and internal gut microbiota. So the multifactorial process or the multifactorial factors for pathogenesis makes the success story in IBD not like that in Clostridium difficile. And up till now, it is in infancy. Most of the studies are not so good because of the dissimilarities existing in patient populations among various research protocols, disease seriousness in participants, and the delivery processes. All these contribute to the up till now, no conclusive evidence because of these dissimilarities. Even also, there may be a latent potential. We cannot gain early success, but maybe in the future, maybe later on after a period, you can get some results, good results. And up till now, it's not clear why some patients with IBD respond impressively following fecal microbiota transplantation and the others fail. Also, whenever we are talking about this transplantation, we must put in mind that one size fits all is not applicable here, because we have, even in the same disease, different phenotypes, different location, and different complications. So we cannot use the same technique in all patients. These factors lead to the less good results of IBD, fecal transplantation in IBD. What about efficacy and safety of fecal microbiota transplantation? The most common short-term adverse events of fecal microbial transplantation included abdominal discomfort, flatulence, abdominal distension, borderline, and low-grade fever. The long-term adverse events were arthritis and arthralgia, urticaria, depression, allergic bronchitis, and partial sensorineural hearing loss. For patients with IBD who have complication or infected with Clostridium difficile, there are good results, but not like when IBD is not present. In patients with underlying IBD, the efficiency of a single fecal microbial transplantation therapy for this application was lower than that in patients with IBD. The results here, 37% of patients reported improvements, and 30% has no change, and 49 or 30% worsened for IBD patients with Clostridium difficile. Serious adverse events included CDI hospitalization and IBD flare, colectomy, small bowel obstruction, pancreatitis, CMV infection, all recorded complication if IBD patient has Clostridium difficile and we apply fecal microbial transplantation. So fecal microbial transplantation has shown safety and efficacy in clearing CDI from patients with IBD, but the results need to be further evaluated. In ulcerative colitis, the clinical curative rate is 53%. The overall clinical remission is 21%, and it works good in adult UC more than pediatric UC. The therapeutic effect for patients with UC is very promising, especially for patients with multiple transfusions together with lower digestive tract. So don't use one transfusion, multiple, and through the lower route. Which UC patient that may gain benefit from the fecal microbial transplantation if you use it early in the disease course or in less severe colitis, but it still can work successfully in severe and steroid-dependent UC. Don't use it in fulminant colitis. They are less likely to give you a benefit, and disease extent has no relation to the subject. In Crohn's disease, it's effective also and decreasing hematochezia, abdominal pain, diarrhea, and fever. But as all of us know, there are different phenotypes of Crohn's disease. Which phenotype of Crohn's will have benefit? It's the inflammatory Crohn's colitis and perhaps in early post-operative recurrence. Those are the patients in Crohn's who will gain a benefit from it. What about pouchitis? In pouchitis, like that with UC and CD, there is a decrease in intestinal microbial diversity play a role in its pathogenesis. Of us know the main stem in treatment is antibiotics and the probiotics. Here we can use it, but up till now, these studies are disappointing. 5 studies, 4 say none of the patients achieved remission. Only 1 study which said that multiple or multi-source fecal bacteria and the many transplants can make. So up till now, it's not recommended. The last item, what about safety of fecal microbial transplantation in the coronavirus disease 2019 era? With the outbreak of the coronavirus, several centers have decreased the volume of routine diagnostic or elective procedures to avoid potential transmission of the virus. Several studies have reported a longer excretion of severe acute respiratory syndrome coronavirus through feces than through the nasopharyngeal route. So this longer period of fecal excretion of coronavirus is not suitable. Therefore, several fecal microbial transplantation centers and stool banks have suspended the active performance of fecal microbial transplantation and the recruitment of fecal microbial transplant donors. Recently, the FDA recommended only fecal microbiota transplantation products generated from donated stool before December 2019. However, it plays a major role in the management of CDI and they cannot be postponed, especially in patients with life-threatening conditions. Therefore, during the COVID-19 pandemic, fecal microbiota transplantation should be considered a non-postponable treatment modality, especially in patients with severe and/or recurrent CDI. A recent study demonstrated the possible application of fecal microbiota transplantation in patients with recurrent CDI during the COVID-19 pandemic by adopting specific changes in the workflow. What are these changes? Very strict workflow of stool donation in which positivity of polymerase chain reaction or for nasopharyngeal swabs, stool, and immunoglobulin M serology should be absolute contraindication of donation. The last word, it's still pending. Now, up till now, we cannot say it is present in the guidelines, and thank you.